Sir, my patient is 18-year-old unmarried female. She is a student of 12th standard. She is resident of Bijnor, Uttar Pradesh. And my patient is 18-year-old unmarried female. She is a student of 12th standard and resident of Bijnor, Uttar Pradesh. History was given by herself and her mother. She presented to us with complaints of progressive difficulty in swallowing following injection of toilet cleaner 2.5 months back on 25th of November. So patient was apparently well 2.5 months back when she ingested toilet cleaner on 25th of November with suicidal intent after a family dispute. She consumed small quantity of tejab or acid, which was clear transparent liquid. Immediately after the injection, she had throat pain and she had sensation, throat pain and burning sensation, after which she developed spontaneous vomiting, which was yellowish in color, and small quantity, which was non-projectile. Next day, she developed blackish colored vomiting, after which she was taken to the local hospital, where she was managed conservatively with IV fluids and medications. NG tube was placed at that time, and her vomiting episodes got settled at that time. However, there was no endoscopy done at that time, and she was started on clear liquids on day 5, and NG tube was removed, and she was discharged on day 7. At the time, there was no history of odynophagia, drooling of saliva, respiratory discomfort, change in voice, chest or abdominal pain. There was no history of ICU admission as well. After the discharge, she continued to have vomiting episodes. Initially, it was occasional vomiting, which later became, later she complained vomiting after almost every meal. She also started having sensation of food sticking in the neck. And after that, she developed difficulty in swallowing solids and semi-solids. She then visited another hospital, and endoscopic procedure was done on 19th of December, which was 24 days after the injection. After this endoscopy, she continued to take liquids, and but she was still having a small quantity non-bilious vomiting episodes. After discharge this time, so 15 days later, on 4th of January, another endoscopic procedure was done. Gradually, her vomiting episodes got subsided, but swallowing difficulty was progressed. At present, she is unable to swallow saliva, and she is spitting out everything. Also, she is having upper abdominal fullness. She has lost 9 kgs of weight in last 2.5 months, and she was then evaluated with abdominal X-ray outside, and then she was referred to our center. Another endoscopy was done at our center, and NG tube was placed on 5th of February. And this NG tube drained around 3 liters of whitish turbid. In the past history, there are no known comorbidities or no history of prolonged medication. There is no history of any surgery in the past, no significant family history. In the personal history, there are no addictions. There is no history of any psychiatric illness or previous suicidal attempts. Her menstrual history is regular with 28 to 30 days interval. Last menstrual cycle was on 18th of January. To summarize, 18-year-old unmarried female without any comorbidities or addictions or psychiatric illness. She presented with history of consuming corrosives with suicidal intent 2.5 months back. She initially had vomiting episodes, followed which she developed a gradually progressive dysphagia from grade 3 to grade 6 over 2.5 months period. She also gave history of significant weight loss over the same period of time. So my impression is corrosive induced dysphagia grade 6 with features suggestive of gastric outlet obstructions.
Yeah. So in such cases, the diagnosis is not a issue because diagnosis is obvious. Go back to the first or second slide. Do you agree with the overall management of this patient, or would you have managed
no,
her
sir.
anyway different?
No, sir. Sir, I would have done differently, sir. I would have done an index endoscopy when she was first visited at the hospital, sir, within 72 hours, sir. So preferably within 24 hours first endoscopy I would have done, sir. Sir, it would have given me about the extent of corrosive injury. Also, it was important for future sequelae and prognostication of the patient, sir.
Sir, can I ask a question? Sir is not there. Yeah. Would you have done would you put a Ryle's tube in a patient with acute corrosive injury?
Sir, there are two schools of thought for this. Some authors preferred putting a Ryle's tube. Their idea behind that is it is useful for providing enteral nutrition. Also, it is useful for future dilatation in case patient develops stricture. In case of migraine disease.
Neeraj, what Dr. Desai wants to know, in this case, Ryle's tube was put without an endoscopy. So
Yes,
it is a blind insertion of Ryle's tube.
Yes, sir.
So that is what the question is. Would you
Sir,
put Ryle's tube
blind insertion
without
of
endoscopic guidance?
blind insertion of NG tube
Yes.
is not advisable in this patient, sir.
Yeah, so that's what you should say first, because here from the history, it is obvious that this was not an endoscopy guided
Yes,
Ryle's tube placement. It was a blind placement. Whenever you are asked a question that how you would have managed the patient differently, first you should say what was done which should not have been done, because this can cause harm.
Yes.
Endoscopy, whether you do or not do, will not cause much harm. It will only probably alter the treatment or prognosis. But placing a Ryle's tube without endoscopic guidance is something which should not be done. So that is the first thing you should say. And on direct questioning, again, rather than saying that some authors want and some authors don't want, nobody, even those who want, they don't place Ryle's tube without endoscopy guidance. They place it when endoscopy is done.
Yes, sir.
Understand?
Yes, sir.
Okay. So going back to endoscopy, actually we lost connection in between, but you did answer. What are the disadvantages or what are the points against an early endoscopy?
Sir, points against an early endoscopy is actual extent of the injury may not be apparent in early endoscopy, sir.
What is the biggest disadvantage? The most important. It is that it is associated with a risk. If not done carefully, if not done by an experienced surgeon, if not done judiciously, it can cause damage. It can cause further injury. And in case of an extensive injury, it can even cause perforation. Isn't it? So that is what, whenever you talk of early endoscopy in a corrosive injury, you have to start by saying that I would request, if you have the expertise and experience, then fine. Otherwise, you say I would request a very experienced endoscopist, and this endoscopy has to be done with utmost precaution, with very gentle. The advantages of an early endoscopy are basically assessing the extent of injury and prognosticating and deciding whether an early feeding port is required or not. And lastly, that you can place a Ryle's tube, which will be used, as you rightly said, for feeding initially, and later it can act as a guide for, because once you have a Ryle's tube, through that you can pass a guide wire, and on the guide wire you can do whatever you want. So it gives you access for future dilatation when an established stricture forms. So you should be very clear in your answer for early endoscopy. And we lost the connection in between, but did you discuss about the timing of early endoscopy, when it can be done, when it should be done, and when it should not be done?
Sir, early endoscopy should be done within 72 hours, sir. In that also there are two school of thoughts, sir. PGI Chandigarh group prefer to do within 24 hours, and after that at around 5 days they do relook endoscopy. But Jaipur group says we should do endoscopy in 48 to 72 hours period.
I think sir's connection again has gone. Okay. What are the dangers of placing a Ryle's tube?
Yeah, Raja, in between I am losing connection because...
What are the dangers of putting a Ryle's tube other than perforation? There are other complications. What are they?
Yes, sir. Ryle's tube will keep the G junction patent, so that will cause constant reflux of the content. That will cause constant lower esophageal damage, sir.
That is also important.
Yes, sir.
Would you neutralize acid with the bicarbonate or?
No, sir. I would not neutralize the acid. because neutralizing agents will cause exothermic reaction, and that will further exacerbate the injury, sir.
When she had this, what is the final diagnosis of this patient based on the history? What does she have?
Sir, she has corrosive-induced esophageal stricture with grade 6 dysphagia, along with gastric outlet obstruction, sir.
So, is this normal for acid injury to cause gastric outlet obstruction?
Yes, sir. Normal dictum is acid licks the esophagus and bites the stomach. So it is common to have gastric outlet obstruction in acid ingestion.
What is the difference between solid and liquid corrosives? This was a liquid corrosive.
This was liquid corrosive.
Between a solid corrosive and a liquid corrosive.
Sir, liquid corrosives will generally pass rapidly, and they have rapid transit time. So they will cause more of damage to the esophagus. Sorry, sir, more of damage to the stomach, and that may cause, if it is taken in large quantities, may cause small bowel or adjacent organ injury as well. But the solid corrosive being more concentrated and it takes more time to ingest, they will cause more damage to the oropharynx and esophagus as compared to.
And discontinuous.
Sorry, sir.
Solid ingestion is discontinuous.
Yes, sir.
Okay, deep burns, but some areas might not be burned. What is the common toxic chemical that is used by patients in normal suicidal injury?
Sir, most of the time, patient use toilet cleaner. Or,
what is that acid? What is the kind of acid that they use?
Most of the time, they. So mostly hydrochloric acid they use.
Sulfuric acid. Sulfuric acid. What is the difference between alkali injury and acid injury in the pathophysiology?
Sir, alkali injuries mostly causes alkali injury causes liquefactive necrosis, and that will lead to transmural necrosis, while acid causes coagulative necrosis, and that leads to HR formation, and that will prevent the transmural necrosis, sir.
Sir, you are getting continuously disconnected. I think
actually today we have logged in from a different geographical location, but now it should be okay. So have we discussed the symptoms of upper abdominal fullness? We've already discussed that.
Partially, not completely.
So,
Neeraj, can you elaborate on this?
Sir, patient had upper abdominal fullness because patient might have had patient has taken acid, so that led to pyloric spasm, and that led to pyloric stricture, sir. So patient is having gastric outlet obstruction, and that was causing recurrent vomiting episodes. So because of the gastric outlet obstruction, patient is having upper abdominal fullness. Also, patient gradually developed esophageal stricture. So gradually stomach is getting distended. That is why patient is having upper abdominal fullness, sir.
But based on history, is there any other pointer to say that she also has gastric outlet? See, patient may say vomiting, but actually it may be regurgitation of the collected food or saliva proximal to stricture in the esophagus. What else is there in the history which suggests that she probably has gastric outlet obstruction? One is upper abdominal fullness. There is something else. Go to the next slide. There was a slide. Go to the next, please.
A patient after this endoscopy, patient was taking liquids, but he was still having non-bilious vomiting episodes, sir. Small quantity.
And when the Rice tube is placed, large amount of
non-bilious vomiting content was drained, sir.
Because suppose there is esophageal stricture only, whatever saliva or whatever liquids the patient is taking, if the stomach and pylorus are normal, that would get normally emptied. The fact that you got 3 liters of whitish turbis fluid, which has no bile, is a strong pointer towards pyloric obstruction. Which Dr. Desai asked you about the pathophysiology of acids versus alkali. Which of these is more likely to cause pyloric injury?
Sir, acids are more likely to cause pyloric injury, sir.
Why?
Sir, uh, acids causes reflex pyloric spasm that will lead to stagnancy of the corrosive there, and that will cause pyloric and pre-pyloric stenosis.
I'm not sure, but I think it's probably because acids have a rapid transit.
Rapid transit is also an important mechanism. They form an scar in the esophagus, so further damage is prevented, and so more acid reaches the distal stomach, and that is the area which is involved with stricture.
Yeah.
Ice can also cause but acid neutralizes the lye, so that prevents the formation of stricture more less in alkali injury as compared to a acidic injury.
Yeah, so the alkali would be neutralized by the gastric acid and is less likely to cause injury to the stomach and pylorus, whereas acid, because of multiple mechanisms, is more likely to cause. Okay, yeah, carry on, please.
Sir, on examination, patient is alert, conscious, oriented to time, place, and person. She was sitting comfortably in the bed with a ball by her side, and she was spitting saliva frequently. Ng tube was seen in situ. Patient is average built and poorly nourished. Patient is WHO performance status of 2. Her BMI is 14.48 kilogram per meter square with height of 162 centimeter and weight of 38 kg. Pallor and pedal edema are present. Pulse rate of her pulse rate of 94 per minute and BP of 94 by 60 mmHg in right arm supine position with respiratory rate of 16 per minute, and she was afebrile. Breath holding time was 30 seconds.
Sorry, another point which we missed in the history, there was another indicator which suggested that there is possibly gastric injury. What symptom would suggest that gastric injury is more likely as compared to esophageal injury? She passed black stools. Bleeding, GI bleed and melena is more likely to be there with gastric injury rather than, it can happen with esophageal injury also, but then you start suspecting. So that was another pointer in favor of possible gastric injury at that time. Yeah, please.
Sir, on examination, there was temporal and supraclavicular hollowing seen. On oral cavity examination, oral hygiene is good. Adequate mouth opening is there. There is no staining over the teeth, and her tongue movement is normal. There are no mucosal lesions or scarring.
So in the oral cavity, what is the most important structure which you look at in a patient with corrosive injury, which can show restriction of movement?
The tongue will show restriction of movement, and if we are able to go up till pharynx, so
no, just simple per oral clinical examination.
Sir, mouth opening will be reduced and tongue movement may be restricted, sir.
Uvula also. Uvula. You can easily see the movement of uvula. Then you should also say tonsillar fossa. You can easily examine the tonsillar fossa. Are there any scars there? So whatever part of oral cavity and oropharynx you can see, you should, in a case like this, you should give a more detailed description of the oral cavity examination.
Sir, on abdominal inspection,
you to do a direct laryngoscopy.
Sorry, sir.
It's important to do a direct or indirect laryngoscopy.
Yes, sir. It is important to do. Sorry, sir. I couldn't hear you. Sorry, sir.
What will you look for in a indirect or direct laryngoscopy?
Sir, I would look for movement of vocal cords, sir, whether they are involved or not, and look for piriform sinus or piriform fossa, sir, whether it is patent or not, sir.
What is the importance of that?
Sir, in case of high strictures where cervical esophagus is not available for anastomosis and doing coloplasty, we will anastomose with the piriform fossa, sir.
Yeah, go on.
On abdominal examination, abdomen is flat and upper abdominal flat with the upper abdominal fullness was inspected. Umbilicus was central and inverted. There was no.
patient होगा उसके यूरिन आउटपुट कितना आया 151
scarred sinuses, dilated veins, pulsations or peristalsis. All quadrants were moving correspondingly with respiration. Cardinal orifices were intact with no visible
Dr. Badri Narayan, please mute yourself. Dr. Badri Narayan. Yes, Neeraj, carry on.
On palpation, abdomen is soft and non-tender. There was boggy feeling in the left upper abdomen and parambilical region. However, there was no organomegaly palpable. Hernial orifices, there was no palpable cuff impulse palpated, and renal angles were free. On percussion, lever dullness started from fifth intercostal space, and lever span was 13 centimeter in right midclavicular line. On ausculto percussion, distended stomach was found reaching up to the left lumbar and infra-umbilical region. Rest of the abdomen was tympanic, and there was no evidence of free fluid. On auscultation, succussion splash was positive, and normal bowel sounds were heard. DRE was within normal limits. Rest of the examination was within normal limits, and on psychiatric evaluation there was no evidence of psychiatric illness, sir. So to summarize, 18-year-old unmarried female without any comorbidities, addictions, or psychiatric illness, presented with alleged history of corrosive ingestion 2.5 months back, with suicidal intent, with progressive dysphagia of grade 6, with features of gastric outlet obstruction. On examination, she is poorly nourished with the BMI of 14.48 kilogram per meter square. On abdominal examination, abdominal fullness was there, along with succussion splash positive, and ausculto percussion test showed distended stomach, sir.
You mentioned that you did a psychiatric examination. Do you know the components of psychiatric? I don't know. So if you say you should know what are the components, and how did you come to the conclusion that she has no psychiatric illness?
Okay, sir. Actually, we took the reference from the psychiatric team, sir.
So say that, then don't say, because if you say it, then obviously I will ask what all did you ask and what are the components. As I said, I don't know, so I can't tell you. But if you say, then you should know. The same is true about neurological examination. In a case that you should, it is better to say that no gross neurological deficit, whatever as a surgeon you are expected to know. Okay, so as I said, that diagnosis in these cases is obvious. Now the issue is, so she's how much time after? 2.5 months.
2.5 months.
Yes. So what will be your approach? What is your overall plan of management of this patient?
Sir, I would first of all review the previous records of the patient, sir. She has underwent 2 endoscopies outside and probably 1 contrast study outside. So
does it matter now when she has absolute dysphagia, grade 6, you said? Does it matter what the early endoscopies showed?
Sir, no, it won't matter for initial planning because we need a feeding access first of all, sir. So first of all, I'll resuscitate the patient with fluids and I'll do the blood workup in the form of an arterial blood gas with the complete blood picture and our serum albumin and PTA.
Go back to the general examination. Go back to the general physical examination. Is she dehydrated?
Sir, actually, when I took this case, so at that time she was already on fluid, so she was not dehydrated.
So then you said that first I will hydrate her. She's already hydrated. If she had any features of dehydration, you should have mentioned that. Then hydration becomes important. Also, the question which I asked, that does the initial endoscopy finding matter at this stage? As far as the esophageal injury and stricture formation is concerned, it doesn't matter because the stricture has already formed and it is causing complete or absolute dysphagia. What it would matter is what was the upper level of injury. So if suppose the initial endoscopy showed that even the cervical esophagus or even the laryngopharynx was injured, then you are anticipating that this is going to be high stricture, which is going to be a difficult stricture for management. Second is the extent, the longitudinal extent of injury. Suppose the entire esophagus was involved, you anticipate or you expect that it will be a long stricture. Longer the stricture, less likely it is to respond to endoscopic management. Length is one of the factors for response to endoscopic management. So it does matter, but not directly. So you are right, but it is more important for the micro planning of the management. So the first step, as you rightly said in this case, at this time, is nutritional buildup. So how would you do that?
Sir, considering the patient is having esophageal stricture as well as pyloric stricture, I would give feeding jejunostomy to this patient, sir.
Will that take care of both the problems?
Sir, we have already placed the NG tube, so we will keep that NG tube for drainage of the stomach, sir. Otherwise, if we are not able to place NG tube, in that scenario, we would also do venting gastrostomy as well, sir.
But at the moment, when you examined her, she has a Riles tube in situ.
She has Riles tube in situ, sir.
Which is draining gastric fluid.
Yes, sir.
Given the choice, would you do a gastrostomy in a patient with gastric stricture? What is the management of gastric stricture?
Sir, no, I would not go for venting gastrostomy. I would still prefer giving Riles tube.
Why?
Sir, there are two reasons behind it. This one thing is stomach is already injured, so that won't hold as well. Also, in future, if patient is having only gastric stricture, that will also alter our management, sir, when we are planning surgical.
If there is gastric stricture, what if the problem? If you have an esophageal stricture and a gastric stricture, you manage the esophageal stricture one way, you manage the gastric stricture another way. What is the importance of a reservoir function?
Sir, when we are doing esophagocoloplasty, we will require the residual stomach, sir. So residual capacity of the stomach we will require. If it is it has lost its reservoir function, then we may need to do colojejunostomy. Otherwise, we will do cologastrostomy, sir.
Yeah, why do you prefer reservoir function? What is the advantage of having reservoir function as compared to a ruined by colojejunostomy? Why do you want a reservoir function?
Sir, it will give us better nutritional outcomes, sir.
So what kind of therapy you want to do in this patient whose stomach is involved? What would you do? You said
sir,
stomach, but what surgery on the stomach?
Sir, in case, not in this case, sir, in case only gastric stricture is there, then we can plan definitive surgery from the stomach itself. Otherwise, in this scenario...
what definitive surgery? That's what I'm asking. What definitive surgery would you do?
Sir, if only type 1 or type 2 gastric stricture is there, we'll do distal gastrectomy along with the either gastrojejunostomy or Billroth 1 reconstruction if possible, sir.
Okay. In this case, if it is not possible, what would you do?
In this case, if it is not possible, then we will go for esophagocoloplasty with the cologastric anastomosis along with the gastrojejunostomy, sir.
Okay. That's what I want to know.
2
what
points.
One versus gastrojejunostomy.
Sorry, sir.
What are the advantages of Billroth 1 versus gastrojejunostomy?
Sir, Billroth 1 will cause bile reflex, persistent bile reflex will be there, sir. And in gastrojejunostomy, there won't be any bile reflex. Also, it may not be possible to do. Yes, sir. It may not be possible to do Billroth 1 in case proximal duodenum is also scarred. That will give us tension, and we won't be able to do.
I am asking you. It is possible to do a Billroth 1. But would you prefer to do a gastrojejunostomy or a Billroth 1? And if it's a Billroth 1, why?
What is the advantage of Billroth 1 over a gastrojejunostomy? And see, in corrosive injury, acid injury, usually the duodenum is not scarred because the moment the acid reaches the pylorus, it causes intense pylorospasm, which prevents the caustic to go from the stomach into the duodenum. So invariably the duodenum is free. So technically speaking, Billroth 1 is possible. What Dr. Desai is asking, what is the advantage? If you choose Billroth 1, what is the advantage? And disadvantage you have already mentioned.
Sir, advantage of Billroth 1 is maintaining the natural passage along with the, we need only single anastomosis in that. while in gastrojejunostomy,
What is
we'll
the advantage of a nasal passage? That's what I want to get at. I'm wanting you to tell me what are the physiological advantages of Bilrot 1. What deficiencies will be prevented?
yes, sir.
Gastro,
The trace elements
gastric reflux, will that be more common?
sir, basically, trace elements, calcium
Which
and,
element?
absorbed in the duodenum and proximal jejunum, sir. So, Bilroth 1 will prevent these deficiencies, sir.
Which ones?
Sir, iron deficiency and calcium deficiency, sir.
Yeah, that's the answer I wanted. One is physiological advantage. Second is duodeноgastric reflux is less common as compared to a gastrojejunostomy, which results in reflux of bile into the stomach. Third, the pancreatic reflex is properly maintained so that the digestion of proteins and fats is better. That is the advantage of doing a Bilrot one. That's why people go through all the trouble of doing a Bilrot one.
Two points which you need to remember and mention also, that the fact that there is corrosive pyloric stricture does not necessarily mean that the stomach body is involved. It could be an isolated pyloric stricture and stomach may be apparently normal. So you should not say that if I do a venting gastrostomy or a GJ, it may not hold. That depends on the evaluation of the stomach, which is of course best done at endoscopy, but a CT also can give you an idea if endoscopy is technically not possible because of a tight esophageal stricture. Second is that this point, which is mentioned in many textbooks and mentioned by many students and by many of us examiners also, that if you are planning to use the stomach as a conduit, then you should not do a gastrostomy either for feeding or for venting. I don't know whether it holds true, because you would do it on the midpoint between lesser and greater curvature in the body of the stomach, which is quite pliable if the stomach is otherwise normal. So you can always remove that gastrostomy, close that opening and still use the stomach, because it should not usually interfere with stomach being used as a conduit. So that's a very soft point. Now here, in this case, you said that rise tube is there. Suppose the rise tube is there, would you prefer the rise tube as the gastric drainage, or would you prefer a gastrostomy as the gastric drainage?
Sir, I would still prefer Ral's tube as the gastric drainage, sir.
What is your overall assessment that how long this patient will have to be on feeding jejunostomy and gastric drainage before you contemplate the final definitive management, which will come later?
Sir, it will take at least 6 months, or it can take up to 12 months as well, sir.
Okay, maybe we'll come back to that question later when we decide. So let's review the investigations. You wanted to see her investigations. Let's review them.
So this was the first endoscopy which was done after 25 days of ingestion, sir, which is showing esophageal circumferential stricture starting from 25 centimeter to 30 centimeter from the upper incisors. And after that, pediatric scope was passed and G junction was at 36 centimeter. Stomach fundus and antrum was showing inflamed mucosa with the pylorus was deformed, and duodenum was cannulated and the distensibility was normal. So at this point of time, there was esophageal stricture along with deformed pylorus, sir. Next was on 4th of Jan, which was 15 days after. And at this time, there is extension of stricture both proximally and distally. Now the stricture is starting from 20 centimeter and it is reaching up till G junction, sir. And pylorus is also completely narrowed, and it was not amenable to pass through the pylorus. So at this point of time, esophageal stricture has extended, and patient has developed gastric outer obstruction features. And subarigular dilatation was also done in the esophageal stricture, sir.
Okay.
Next was the barium study, which was done. So this is showing long segment esophageal stricture, and at this point of there is narrowing in the cervical esophagus itself, and almost complete narrowing in the throughout the esophagus. Also, in this side, we are able to see distended stomach with the contrast is filling, contrast is trickling along the settling along the greater curvature of the stomach, sir. So it is going up till pelvis, sir. These are the oblique films of contrast study, which shows long segment esophageal structure only, sir. And
do the endoscopy and barium findings tally with each other?
no, sir, because with this long segmental narrowing and this much of narrowing, we wouldn't have been able to pass up till the such stomach, sir. But this barium study was done around 25 days after this last endoscopy, sir.
You should have mentioned that, because obviously the upper level of the stricture is not the same as shown on endoscopy. Endoscopy showed 20 centimeter. 20 centimeters means 5 centimeter below the pharyngeus. This, to me, this appears to be very high.
Very high.
So there is discrepancy, and probably the stricture is ascending. It is still evolving.
It is still evolving, sir. One endoscopy was done after this as well, sir, when the NG tube was placed finally. So this is that endoscopy report, which showed stricture is noted from the 18 centimeter itself, sir.
With these findings, what would you like to do?
Sir, at this point of time, I would like to go for, sir, give the feeding jejunostomy to the patient, sir. And we will build up the patient with enteral nutrition. And also, I will counsel the patient regarding the further management of this issue, sir. That
suppose there is no pyloric stenosis.
Yes, sir.
And you could use the stomach. And would you prefer a gastrostomy or a feeding jejunostomy?
Sir, in that scenario, if the pyloric stricture is not there, I would try to give and place NZ tube if possible.
Okay.
Yes, sir. And
why do you, if you cannot put an NG tube with an esophageal stricture, and you know that the stomach is not involved based on CT, what would you prefer? Would you prefer a gastrostomy feed, or would you prefer a jejunostomy feed? What are the differences between gastrostomy and jejunostomy?
Sir, I would prefer gastrostomy feed. I would still prefer a jejunostomy feed, though giving feeding would be better with gastrostomy. But considering the stomach is not involved and pyloric stricture is not there, we may utilize the stomach as a conduit in future. So I would not do gastrostomy in that scenario, sir. I would still do feeding jejunostomy, even though results with the feeding results with the gastrostomy would be better, sir.
Yeah. What are the differences between gastrostomy feeds and jejunostomy feeds?
Sir, gastrostomy feeds we can give in bulk because the patient has receptive capacity of the stomach, sir.
What about osmolarity?
And yes, sir. Also, we can give high osmolar content as well, because it will be diluted with the gastric juices, and it will go through the natural passes. So that will help in.
What is the danger of giving a high osmolar feed in jejunostomy?
Yes, sir. So in that scenario, patient may develop loose stools because of this thing, sir. And patient will give features of early dumping as well, sir.
What about dangerous complications? What dangerous complication can occur with high osmolar feed? You can get mesenteric venous thrombosis because of injury. Because of rapid removal of fluid from the blood vessels, you can get mesenteric venous injury also in high osmolar feeds, in addition to dumping. What about Billrot 1 versus gastrojejunostomy? Which has more dumping?
Sir, gastrojejunostomy will have more dumping.
So why is early dumping and late dumping less in Billrot 1 as compared to GJ?
Because, sir, the content will be mixed with the bile and pancreatic juices along with the proximal jejunal secretions, sir. So that will comparatively dilute the content and osmolarity will be reduced. So that will cause less of dumping in
Billrot 1, sir. Mechanism of early dumping. The reason is in early dumping, it is an altered gastrojejunal reflex. Basically, what happens is you get cytokines and hormonal manifestations hormonal secretions of the gut are more abnormal in gastrojejunostomy as compared to gastroduodenostomy, because the duodenum is reflexly in reflex. It is a more normal pathway as compared to a gastrojejunostomy, and rapid distension of the jejunum results in release of small molecules which mediate vascular dilatation and tachycardia, and that leads to more dumping in gastrojejunostomy as compared to Billroth-1. Normal passage being maintained, normal duodenopancreatic axis being maintained is very important in the prevention of dumping. You should not think it is osmolar load alone. Previous concept was osmolar load, but now it is believed it is neurogenic. Early dumping is neurogenic. What is the difference between early dumping and late dumping?
Sir, early dumping will have will be because of one high osmolar content and neurogenic mechanisms. Late dumping would be because of the
Early dumping
high,
is hypoglycemia.
because of the high insulin secretion. Because a patient because high osmolar content or high sugary content will reach the jejunum, and that will go into the circulation, that will cause excess of insulin secretion, so that will lead to hypoglycemia, sir.
Hypoglycemia. Delayed hypoglycemia. Okay. Sir is not there.
No, I'm back. So in this film, what I wanted to point out that because the contrast is at the greater curvature, initially you may think that the stomach is scarred, but if you see carefully, there is large amount of air. There is an air fluid level there. So it is that because of probably the position of the patient, the contrast has gone on one side, and rest of the stomach is full of gastric juice. So it is a distended stomach, which you can make out in some other films also. That is what I wanted to point out. So here, the pylorus has borne the brunt of the injury, whereas the rest of the stomach is probably not injured to that extent that it has got scarred, because it has distended to the level that you could aspirate 300 ml of non-bilious fluid from it. Yes, please carry on. Have we discussed the indirect laryngoscopy?
Sir, this is the indirect laryngoscopy of the patient with bilateral true vocal cords are mobile and glottic sync is adequate. Both valvular epiglottis and true and false vocal cords are normal, and bilateral aryepiglottic fold and piriform sinuses are normal, sir.
So when it was asked that what would you see on direct and indirect laryngoscopy, these are all the structures which you need to mention.
Suppose this patient had a lot of aspiration. What are the changes in the indirect laryngoscopy that you would see?
Sir, initially, sir, if we do in acute phase indirect laryngoscopy, that time we can found ulcers on the vocal cords or epiglottis or valvular.
Inflammation and edema you would see in the false vocal cords and the epiglottis, and the epiglottis could be inflamed.
Okay.
Also, you should look for what is the importance of epiglottis. The importance of epiglottis is it can be scarred by corrosive injury. Because once the epiglottis closes, acid flows over it, it can cause corrosive injury to the epiglottis and stenosis and stricture and scarring of the epiglottis, which will impair its movement, which leads to increased aspiration after esophagocoloplasty. Sorry. That's why it's very important to have a normally functioning epiglottis, normally functioning larynx, before you think of doing a pharyngocoloplasty or a esophagocoloplasty.
Sir, these are the blood investigation of the patient, sir. Her hemoglobin is 8.7, so she is anemic, and apart from that, her albumin is 2.1. Rest of the parameters are normal, so she is having anemia, likely because of the two reasons: malnutrition and the illness itself. And patient is severely malnourished, and which is shown with the albumin levels at 2.1.
So now going back to the definitive management, what is the plan for definitive management of this patient?
Sir, after building up her nutrition, and I would plan for sir. In the end, I would.
After 1 month, her hemoglobin is 12 and her serum albumin is 3.6.
Yes, sir.
There's no fetal edema.
But I would still wait for the time being, sir.
Right.
I would give a stricture to stable. I will give time for the stricture to stabilize. And
How much time?
sir, minimum 6 months, and we can wait. If it is still progressing, sir, we can wait up to 12 months as well. So in the
So
meantime, we will.
All
Sorry, sir.
modalities of treatment, you need to wait for 6 months, or something you can do earlier than 6 months?
Sir, I would go for endoscopy in the meanwhile, around 4 or 5 months, and if it is still there, and we found that stricture is still progressing proximally, so we would try to keep its patency with either a Riles tube, or if it is not possible, or if it is not feasible, then we can think of doing sir, right side cervical esophageostomy if possible, or mycocutaneous flap on the right side, and which will in later on we will explore the left side neck and do side to side pharyngocoloplasty, sir.
What about what do you consider as failure of dilatation? Is this a failure of dilatation?
No, sir, this is not failure of dilation. Failure of dilation, we say if we are unable to achieve 14 mm of diameter, esophageal diameter, even after 5 sessions of dilatation at 2 weeks interval. So that would be failure of dilatation, sir.
That means 10 months, 10 weeks, only 2 months. You are not able to attain a stable stricture for a period of 6 months, and you are not able to achieve a lumen size of 14 to 20 millimeters of millimeters, then you would consider failure of dilatation or development of perforation or involvement of the stomach, in which case dilatation will be difficult. But now these days with balloon dilatation, it is still possible to dilate the esophagus even though you don't have a gastric reservoir. Previously, where they used to use Savary Gilead, Muzobarbin, and different mercury dilators, they needed an intact stomach because you're passing the guide wire into the stomach and dilating over the guide wire. But nowadays with balloon dilatation, which is Rigiflex, you don't need the stomach reservoir to be present. Why are we so desperate to retain the esophagus?
Sir, one thing is the morbidity associated with the esophageal replacement. Other thing is if natural esophagus is patent, it is functionally much more. It's functionally much better than either doing gastric pull-up or colonic pull-up, and also patient may need to relearn the swallowing process after pull-ups. So preserving the esophagus will not require that relearning. So
what could be the mechanism for being unable to dilate and maintain the dilatation in this patient?
Sir, persistent scarring process is ongoing. One thing. Other is if the patient developed endoscopic dilatation related complication, as in perforation or diverticular formation. So that can be the concept.
The 6 months waiting is for us, for surgical management, because we don't want that at the site where we are doing the anastomosis of the esophagus to the conduit gets scarred and strictured. But that is not essential for endoscopic management. Endoscopic management can begin even earlier, because even if the stricture progresses proximally, they can continue with dilatation. Second, in the exam, in the practical exam, when we are asking questions, most of the questions are related to this case. This patient already has a Riles tube in C2, so you should not have mentioned whether Riles tube is passable or not. Obviously, it is there. So even if now you do an endoscopy, as I said earlier, once a Riles tube is there, a guide wire goes through it. Once you have a guide wire, most endoscopists would be able to place a Riles tube. So that question, that situation doesn't arise here. Now, so in this case, suppose her nutrition, and actually nutritional status is not a prerequisite for dilatation also. You can do dilatation in a patient who is not adequately nourished. So in this case, why not dilate the esophageal stricture and why not dilate the pylorus?
Uh, Sir, this stricture is quite long stricture. So long strictures which are longer than 10 centimeter are mostly not do not give good results with dilatation. So they are considered for surgical. They are considered as surgical candidates.
What are the other factors which can predict failure of dilatation? Failure, Dr. Desai has already defined for you.
Sir, if there are multiple strictures more than 3, and if length of stricture is more than 10 centimeter, if there are if there are endoscopic dilatation related complications like perforation, and there are simultaneous diverticulum formation along with it, so these are difficult to dilate.
Anything about angulation, tortuosity?
Yes, sacculation. If there are sacculations present in the esophagus, sir.
What happens if there are sacculations in the esophagus?
Sir, because the guide wire will coil there itself, and that can lead to iatrogenic perforation, sir.
Okay. What is the importance of G junction in planning surgery of corrosive stricture? Whether G junction is patent, whether G junction is patulous, what is its importance in esophagocoloplasty?
If you are not doing
Yes, sir.
esophageal resection.
But if we are not doing esophageal resection, G junction is not patent, then we need to do side-to-side anastomosis to prevent the mucosal formation. Otherwise, if the G junction is not patent and we do end-to-side anastomosis, there will be mucosal formation, sir. And
very important thing you should remember is if there's a patulous G junction because of burn injury to the sphincter, the incidence of reflux esophagitis is more. So the chances of forming of Barrett's in the remnant esophagus, the chance of malignancy and forming in the esophagus that's left behind, and also the incidence of stricture being unpassable and undilatable is also because of a patulous D junction. Because acid keeps refluxing and causing further stricture and damage. So that is the importance of the G junction. What if this patient had an undistensible stomach? What would your plan be?
in case patient had undistensible stomach, so I would do, sir, upper. I would do esophagocoloplasty with the colojejunostomy down, sir.
You want to leave the stomach behind or you want to remove it?
Sir, I will leave the stomach behind.
Native esophagus, native stomach, do you want to remove it?
No, sir, I won't do resection. It is quite morbid surgery, and I will do esophagocoloplasty with the colojejunostomy, sir.
What happens if you leave the stomach behind is you can get a gastric abscess. Pus accumulates, secretion accumulates, gets infected because there is a proximal stricture and a distal stricture. And they can get severe pain and fever. So if the stomach is scarred, it's better to do a total gastrectomy, if possible esophagectomy. Nowadays they say prefer to remove the esophagus because of the chance of malignancy. Previously we never used to remove the esophagus, but current management is to try to remove the esophagus and also to remove the stomach and do a esophagocoloplasty and a colojejunostomy. What about antiperistaltic versus isoperistaltic conduit?
Sir, if the
Rajan, I think maybe we will ask Neeraj to continue this in the next session. The details of surgical management, indications, timing, and
Yes,
because there are so many aspects which need to be discussed. In the meantime, I would suggest all students to watch the master class on corrosive stricture, because many of these questions which we are asking, you will find the answers there and you will get more knowledge from the previous master class. So Neeraj, please let Dr. Anand know. I think it would be good if you continue from
Yes,
the summary of this case, and then we can discuss the management. We haven't discussed several aspects of dilatation versus surgery, and then the details of surgery also. So request Dr. Anand to give you a slot, and then we can discuss this.
Okay, sir.
Okay.
Okay.
Thank you.
Thank you, sir.
Thank you, Rajan. Thank you very much.
Thank you, sir. Thank you.